Good morning, everyone. Welcome to the 2024 ICES Research Forum, Strength in Numbers, Partnering for Impact. My name is Leslie Plumtree. My pronouns are she, her, and I'm a staff scientist at ICES. I'm pleased to have you join us for the morning concurrent session, supporting community-driven research through ICES's Applied Health Research Question, or ARC program. Today, our speakers will provide an overview of ICES's efforts to promote analysis of its data by community organizations, and this will be demonstrated by highlighting work from a recent ARC request from the Black Health Equity Working Group. Just a few housekeeping items. If you need help at any time using the platform, please contact the help desk by clicking on the icon in the main menu on the homepage. A reminder that today's sessions will be recorded, and recordings will be available on the YouTube ICES channel after the forum. Closed captioning has been turned on for all sessions in the studio today. And please post any questions in the Q&A tab, not the chat tab that you'll see next to it. We'll be saving questions for the end of the presentation when we bring up the panel of the presenters. However, we do have some poll questions in two parts of the presentation, and we will direct you to the polls tab or polling tab, which is next to the Q&A tab in the menu bar. So without further ado, I'll hand it over to Laura to get us started.
Great. Advance here. Thank you so much, Leslie. And thank you everyone for joining us today. My name is Laura and I'm the Senior Manager of Public and Community Engagement Knowledge Translation here at ICES. And I'm going to provide some background on the Applied Health Research Question Program that Leslie was mentioning, and then dive a little bit deeper into how our team at ICES is helping to promote this program to organizations serving equity-deserving communities. So before we begin, if you do kind of hover over on your right-hand side of the screen, you will see our first two polls, just to give us a sense of how many folks in this session are aware of the ARC program or the Applied Health Research Question Program, and whether or not you've used or been involved with that program before. So please take a few seconds, start to click on the answers to these two very brief questions, and I'll just give you a few seconds to complete this. And this really just helps us to get a sense of, who's in the session today? Are you familiar with this program? Have you used it before? And really kind of your background and where you're coming from as well. So I'll just peek over a couple of votes coming in. I'll give folks a few more seconds and then we'll proceed forward. So some of the early votes I did see coming in, it looked like folks maybe didn't have a lot of familiarity with the Applied Health Research Question background or haven't used it before. And then a few of you may actually have a good awareness. But for those of you who don't, I'll provide a brief overview of the program and just give you a little bit more context. And even for those who have been involved, perhaps it's been some time since you were last involved, or maybe you haven't totally been up to date on some things that have changed. So we'll give a little bit of an overview now as well. So organizations across the province of Ontario rely on different research findings, and it's often to improve the services they provide to communities. But many organizations may not have the means to pay for analytic services or the resource to actually obtain research and analytic findings. So back in 2011, the Ministry of Health created the Applied Health Research Question Program to help Ontario-based organizations connect with health data institutes like ICES and others that provide tailored analytic services. And we'll dive a little bit deeper as well into kind of a definition of this program. So an Applied Health Research Question is a question posed by an organization to obtain research and analytics that help inform planning, program development, and really the crux of this is to improve services for communities across Ontario. So you may also be wondering, what are some past Applied Health Research Question projects that have been conducted before? Kind of what do those look like and who is conducting those? So this is just a very brief snapshot of some example projects. Obviously, there's many, many more available on the website as well that you can take a look at. But just to give you a sense of things, back during the COVID-19 pandemic, there was a project on COVID-19 testing among vulnerable populations. There was also a project looking at health services cost breakdown for a family health team. There was evaluation of a virtual emergency department, management of type 1 diabetes in school-aged children, and then kind of more on a geographic level, cancer screening rates, so breast, colorectal, and cervical for the central Lynn region of Ontario. So as you can see, it's quite a wide variety of projects, both at a larger scale and a smaller scale as well. So in addition to some of these past project examples, there's also a dedicated stream to Indigenous-driven ARCs. And in an effort to work towards reconciliation, the Ministry of Health has allotted a portion of the ARC funding for requests from Indigenous communities, groups, and organizations to address health questions about their communities. In 2022, ICES implemented a modified ARC process to reduce barriers to accessing data and provide Indigenous communities with information in a timely as well as a culturally safe manner. This was enabled by having a dedicated team of ICES staff with an understanding of Indigenous data sovereignty, who can help build relationships with Indigenous partners and support the ARC process from idea to final knowledge product. Some examples as well have been individual communities coming forward, groups of communities, Indigenous organizations, as well as leadership organizations. So if you'd like to learn more about the Indigenous-driven ARCs, or if you're a part of an Indigenous community or an organization and are interested in requesting an ARC, please don't hesitate to contact the ICES Indigenous Department at indigenous@ics.on.ca. That also brings us to, who else is participating in ARCs? So this is kind of a snapshot of kind of very close to inception all the way to 2022 in terms of who's been participating. And as you can see, since early inception, most ARCs were conducted by the Provincial Ministry of Health or a government health agency, along with others. And others include federal agencies or organizations. Now, community level organizations, which is that light teal on the screen in the bar graph, were still quite low at early onset. So you can see around 2012, 2013, there weren't many community level organizations conducting ARCs. Now, there has gained more interest in recent years, and you can see that light teal has grown over the years. But it's still an area we're looking to grow, and we want to continue to support this at ICES. So that kind of brings us to our question and the work that my team has been working on, which is how can we increase awareness and support more community-driven analysis projects? So to answer that question, we have to go back a little bit and talk about some of the work that we've been doing at ICES that really has been kind of pushing this forward. So the guidance document and framework at ICES is a guidance document for anti-racist approaches to research and analytics. And if you aren't familiar with it, it was first released in September 2023 and really creates a path forward to organizational approaches that support research that uses and governs race and related data appropriately. So there's the larger document, and there's also a smaller executive summary. Now, I'll describe a little bit about the principles for appropriate use of race and related data in this document that help to inform the work we want to do going forward, which includes increasing awareness of the ARC program. So as you can imagine, to develop this framework, there was a lot of foundational work that supported the early conceptualization of the document. So two that I really want to highlight today are the work of the Indigenous Department at ICES and the work of the Black Health Equity Working Group, which you'll hear more from later in this presentation. So internally, we want to highlight the work of the ICES Indigenous Department with their partnerships with First Nation, Métis, and Inuit communities, and health service provider partners across urban, rural, and remote geographies. The framework was informed in part by the Indigenous Data Governance Principles Framework, which you can see here on the slide, which was initially developed in collaboration with the Chiefs of Ontario and the ICES Indigenous Department for First Nations Data and Research. It has since been adopted for ICES's work with all Indigenous data and research. Now, given the distinct approaches and existing work well underway, the guidance document does not address Indigenous identifiers or data within its recommended action. But we do encourage you to visit the ICES Indigenous Department page on our website to learn more about the work that is underway. In terms of external efforts, another key document that helped to shape the foundation of this work was the Black Health Equity Working Group's Engagement, Governance, Access, and Protection, or EGAP framework. And this really described governance needed for the collection, management, analysis, and use of data from Black communities. The creation of ICES guidance document and framework to guide appropriate use of race and related data was in part first created to address the EGAP recommendations and the call for research institutes to improve data collection, use, and governance. We very much recognize the importance of both these documents as a starting point for our own work. So that brings us to the framework within the guidance document. And as you can see, it outlines 4 key domains of action as we move forward as an organization. Each has specific components that we commit to. Now, in particular, I'm going to talk and focus mostly today on the community access domain, which is a key pillar of this framework and really what's been guiding the work forward with the ARC program. So the community access domain is focused on creating pathways for community organizations that serve racialized and equity deserving groups to use our ARC program and have support for these services. So within the domain of community access, we want to focus on 2 components. Number 1 is increasing awareness of our ICS data and analytics services through the ARC program. And 2, building mutual capacity within community to help understand contextualization of the data and provide tools to support communities in using these results to improve services. In the short term, many community organizations may not be aware of the ARC program or potentially ICS as an organization. So we're in the process of creating more tailored tools for community organizations to help explain the ARC process, what it can and cannot be used for, and really hoping to also gain insights through community consultations with groups who have used the ARC program before, as well as those who have not, to really help to co-design these materials and understand what might be needed to help explain these resources that are available. Now I'm going to talk a little bit about what we've been doing in terms of creation of those products, and based on insight from community organizations who have used our services, as well as, again, those who have not and what they might be looking for. And the work that we're doing right now really has 3 intended outcomes. We want to increase awareness of the ICS data and analytics services, and we want to also increase engagement. So creating pathways for open communication with community organizations, for outreach, as well as inquiry as well. And then ultimately, the real end goal here is use. We want to see more community-led ARC projects or proposals submitted and ultimately conducted from start to completion. So there's kind of 3 steps in this work so far. So the first is an environmental scan, which is really helping us to define the deliverables. This was an informal review that we began by reviewing existing web pages, videos, written materials from healthcare research settings, as well as community organizations that really had products tailored for the community or for a nonprofit sector. What we found was that a lot of the projects used plain language and were interactive in some way. They often had testimonials to kind of humanize the work that they're doing and very clear calls to action. Overall, having a personal feel to products was important, which makes sense given we know that the work directly impacts communities and individual people who are behind the data. The next step, and one that's currently ongoing, is community consultations. So really thinking about creating those deliverables. So in spring 2023, we asked 13 members of the public or community representatives their thoughts on what mechanisms would help build awareness of the ARC program. And there's kind of 2 big takeaways from these discussions. Number 1 was the importance of expanding communication channels and collaboration with organizations and products. And the other was to help kind of co-design these materials with members of the community. Then we moved forward in summer 2023, and based on the results of the environmental scan and community consultations, we were leaning towards a revised interactive webpage, as well as a brief testimonial type video. We took these very rough drafts back to community organization representatives, both those who have and have not used the ARC program before, to gather insight on these ideas. More takeaways that came from these discussions included providing tangible information that communities need when deciding to do an ARC. So in other words, understanding what the application to submit an ARC looks like, what some example projects look like in the past, and really giving some information on how to fill out those fields and also what data we have. And also the other important piece here was, again, humanizing that work, making it seem relatable and understandable. So what's kind of currently happening now in spring 2024, as well as in the near future, is usability testing. We've started to make a very rough draft of these products, which you'll see on the next slide. And now we kind of want to take it back and understand if we've hit the mark here, what are we missing? And really at the end of the day, are these two products going to be helpful and useful for community organizations or representatives that may want to use this program? So this is a very brief snapshot of the product creation. These deliverables are still in draft form. We've actually just very recently finished these. And really, they've only been reviewed so far by our team, as well as a community partner that we have on this project. And our community partner will also be help facilitating focus groups, which is how we'll start to understand the usability testing and really gather feedback so we can refine these products further before an ultimate release. So to wrap things up, I want to tie this all together to talk about implementation and long-term action with this initiative. So part of this endeavor, it's not only to create products, but ultimately we want to build relationships and sustain relationships with community organizations we haven't worked with before. As part of this relationship building, we also want to make sure we think critically about who we need to reach. For dissemination, rather than a mass social media campaign or kind of a broad sharing, we want to think carefully and critically about dissemination to organizations who may want or really need these services as well. When it comes to metrics, we want to make sure that these products are being used and ultimately serving those who we are targeting. So monitoring includes watching the video and website visits, and offering organizations the opportunity as well to provide feedback is very important. As mentioned, ultimately seeing if these products contribute to more projects being conducted by community organizations is really the end goal here. And finally, we want to continue to learn and grow from this work. Our hope is that the continued feedback and relationship building with organizations allows us to grow and adapt these offerings as needed in the future, potentially creating more or expanding on those that we have. So now that I've provided some background on some of the work we're doing to increase in community access to data and analytics at ICES, I'll hand it over to Cynthia Damba to walk us through a real example of health equity research and analysis in action using the ARC program.
Good morning, everyone. Thank you, Laura. Next slide. Thank you. Next slide, please. We'll be talking about presenting a profile of health equity, the health equity profile for CHC clients and non-CHC clients, which was possible with the support of ICES through the ARC project. Today we are presenting this work as part of a larger project team who have been working on this ARC. We are thankful to the ICES team who have been very supportive of this. And we have a knowledge user group, as you've heard, the group that asked for this research included people from Ontario Health, the Black Health Equity Working Group, the Alliance for Healthier Communities, and Parkdale Queen West, Wellesley Institute, and CAMH. Unfortunately, some members from the Alliance and CHC were unable to attend today. Next slide, please. So I'm presenting the next two slides on behalf of Jennifer Rayner, who was not able to attend. In Canada, there's long-standing evidence of health inequities for racialized groups, which was most recently seen with the COVID pandemic. The Canadian Medical Association released a report suggesting that 60% of our risk of illness is linked to social determinants of health, and another 25% is due to variations in access to health and social care. There are many social determinants of health, and there's intersect so that some groups end up at much greater risk than others. Racialized groups are more likely to be exposed to all of the social determinants of health because of the systemic nature of racism. The ARC request came about because hospitals in COVID hotspots and high priority communities that also serve Black and racialized groups had earlier ramped down of surgeries and later resumption. Hence, these marginalized communities may have been more impacted by the surgical ramp down than patients who were accessing hospitals that were less impacted. In addition, there are known disparities in cancer screening with lower rates among individuals with lower socioeconomic status and racialized groups. These groups could also have been impacted disproportionately by change in access to services during the pandemic. So next slide, please. So there was really an opportunity. Next slide, please. There was really an opportunity to look at these disparities using CHC, Community Health Center data, as they do collect racialized and equity data. Community health centers in Ontario belong to the Alliance for Healthier Communities. They serve diverse communities and are committed to advancing health equity through the delivery of comprehensive primary care. The Alliance has a common evaluation framework, which you see, which is designed in the context of the model of health and well-being, and it outlines the values and principles that unite the Alliance members. It sets out a set of characteristics that all CHCs have agreed to and operationalized, and which includes a strong focus on health equity, social determinants of health, community development, and ownership, and interprofessional team-based care. From this model, CHCs have a set of standardized data elements, which include collection and use of social determinants of health data, which were foundational for this project. Next slide, please. As you've heard from Laura and Leslie at the beginning, the Black Health Equity Working Group was a major component in this ARC request. The Black Health Equity Working Group is a group of Black health sector leaders and health equity experts formed during the COVID pandemic in response to the disproportionate impact to Black communities. It was formed to address concerns about lack of tangible benefits of race-based data for Black communities and misuse of data. The group developed the EGAP data governance framework, which stands for Engagement, Governance, Access, and Protection, which you've had Laura refer to. It works to ensure there is a focus on ethical and appropriate use of data to create pathways for advancing health equity. Building on this momentum, Ontario Health has jointly developed the Black Health Plan with community members, health leaders, and academics in response to long-standing systemic health inequities experienced by Black communities. The plan is a call to action to reduce disparities and advance equity in Ontario. It also provides a template to inform planning and action for other populations facing systemic disadvantage. The Black Health Plan has 3 pillars, which are equitable pandemic response, health system recovery, and sustained health equity for Black populations. This ties in well with the goals of the project, which was to explore disparities and impact of COVID on access to cancer and screening and wait times for Black communities. So then we'll move into the next section of actually getting the results from the analysis. But before we do that, we have a poll, which you can see from the chat. If you can turn your attention, we have 2 questions in the poll that ask about whether you've used equity data. Okay, So for the first question, we are seeing about 50% of the audience have actually used patient-level information such as race, ethnicity, and income, which is great. And a good number have also used ecological information. And for the second poll, I think the most, which is looking at the biggest challenges related to collection of interpretation and use of data, equity data. Lack of proper socio-demographic data is coming out in the lead, but several other components like lack of knowledge of equity analysis, interpretation of the data, and limited access are showing up. Thank you all. I'll hand it over to Luke from this point.
Morning, thanks, Cynthia. My name is Luke Mondor. I'm a staff scientist here at ICES, and I'm going to be talking about the ARC work that we did for this project. And the main objectives of this ARC project were to compare differences in surgical wait times and cancer screening rates for community health center clients using individual level socioeconomic status and race-based data compared to a community control group of non-CHC clients. Next slide, please. To conduct this work, we accessed a number of data holdings at ICES. These included, but were not limited to, the CHC data itself, obviously to identify the CHC population. PCPOP, or primary care population, is a data set that includes all individuals in Ontario at different time points that are alive with a valid OHIP card. Within this data set are calculated cancer screening measures, as well as a number of different characteristics of the population. Wait time information system, obviously for our wait time outcomes, as well as OHIP, or Ontario Health Insurance Plan data set for understanding primary care use in Ontario. As well, we accessed ICS-derived cohorts, not to be confused with disease registries. These are data sets derived in-house and include individuals that have met a case ascertainment algorithm for certain conditions of interest. Important to note, as with any ICS study, these data sets were linked using unique encoded identifiers. All the analyses took place in-house on secure servers, protecting patient-level data. And the knowledge user received aggregate-level summary tables, and that is what we will be talking about here today. Next slide, please. So what did we do to address this question? We conducted a repeated cross-sectional analysis. And in that type of study design, what we're trying to do is identify a target population at multiple points in time and describe the characteristics and describe the outcomes. The time period of interest was April 1st, 2018 to April 1st, 2022. So we had 9 cross-sectional panels, so every April 1st and every October 1st from 2018 to 2022. The target populations that we explored, obviously the CHC clients. These were individuals that had 1 or more physician or nurse practitioner encounters at a CHC in the prior 2 years. And we worked, the ICS team worked with the knowledge user on this to categorize individuals in the CHC population into self-identified race categories. And you can see the categories on the screen here. They included those that self-identified as Black, those that self-identified as non-Black racialized, those that self-identified as white. Additionally, we included a 4th category here, those where missing race data or where race data was not available. You'll see in the data, this was a fairly large group, and we wanted to retain these individuals in the sample. So those are the CHC clients. We also included a general population comparator group. These were individuals from PCPOP. They were individuals using primary care services, but were not CHC clients. We matched these individuals 4-to-1 to the CHC group that self-identifies as Black on sex, on birth date within a year, and geography. Geography was FSA, which is 3-digit postal code. And so by matching on those 3 characteristics, what we're trying to do is get a similar profile of individuals in terms of socio-demographics. Important to note, with the general population comparator group, there's no race information available, as it's not commonly found in our standard ICES data holdings. Next slide, please. We had 6 outcomes total, 3 cancer screening measures: colorectal, cervical, and breast cancer screening, and 3 surgical wait time indicators, including the number of individuals who underwent a surgery or surgical volume, average time patients waited for the first surgical appointment, or wait 1 if you're familiar with this data, and average time to a completed surgery. That's the wait 2 indicator, if you're familiar with wait time information system data. I'm just going to say up front, this was a descriptive analysis. We did not perform any multivariable adjustments controlling for important covariates of interest, but really the goal was really just to describe the observed data and to get a sense of gaps in care and differences in not only the descriptive profile, but the outcomes of interest. Next slide, please. So we're going to move into the results of this project next. But I just would like to highlight what we're presenting here today is the result of a few community engagement sessions that took place from January to April. And in these sessions, we presented the results to these groups and really allowed an opportunity for discussion of the data, to provide some opportunity for questions and opportunities for commentary, so that we presented the data kind of as we saw it, what we thought were important differences, but also allowed the audience to kind of comment as well on differences that they saw, what was important in the data. And what we're presenting here today is kind of a result of these community engagement sessions and the information that we gathered from them. So moving into the tables, next slide, please. We're going to be presenting a few tables here characterizing the profiles of the study population at April 1st, 2022, which is our most recent time point. You can see the tables are, the columns of the tables are the study population groups of interest. So we have about 13,000 individuals that self-identified as Black, 28,000 that self-identified as non-Black racialized, 63,000 that self-identified as white, and 172,000 are about 2/3 of the population where race data was missing in the CHC data. Then on the far right, you can see the matched non-CHC population group, and there's about 52,000 individuals in that group. And if we look at age, sex profiles of these groups, you can see for those that self-identify as Black, the average age is about 37 years, and that's about 14 years younger than those that self-identify as being white. Similarly, there's some sex differences as well. About 65% of those that self-identify as Black, 65%, which is quite a bit higher than the other groups. For example, those that self-identify as white were about 58% there. As well, the next 2 variables that we're highlighting here, these are area-based measures of socioeconomic status. So neighborhood income quintile, derived from census data, and material resources, which is from the Ontario Marginalization Index. These are quintile data, So we would expect that if the population were evenly distributed across the groups, we would expect to see about 20% of the population in each group. But really what we're seeing here is an overrepresentation of individuals from the lowest income areas or from the most marginalized areas of the province. You can see about 57% of the self-identify as Black CHC group reside in the lowest income areas of Ontario, or the most marginalized in terms of material resources. And just to note as well, we did match our non-CHC group on geography, FSA, but you can still see that we didn't quite capture individuals from the same neighborhoods per se, because we're not quite seeing that large of a gap or that same distribution across these socioeconomic variables. Next slide, please. One of the nice things about this study and using the CHC data is that it's got equity data captured that we don't otherwise see elsewhere in our health administrative data holdings. So 2 examples include the gender that an individual best identifies with, as well as the primary language spoken. Just highlighting here that those that self-identify as non-Black racialized, roughly 30%, their primary language was something other than English or French, which is quite a bit larger than the other groups in the study population. And last on this slide, we can describe the CHC focus type. This is the categorization of the CHC in terms of the population that they serve. And you can see some of the categories include rural or urban geography. There's a urban at-risk group, which is, this includes CHCs that are typically found in urban centers that address issues such as homelessness or substance use. We have a category here for Francophone populations, as well as newcomers. For the self-identify as Black CHC group, roughly 30% are affiliated with a CHC that focuses on newcomer populations. And if we jump to the next slide, we can see that this aligns fairly well with our OHIP eligibility data, which we would see about 36% of individuals in that group are new to Ontario within the last 10 years. And that, again, is quite a bit higher than the other groups. Homelessness at ICES, we have a definition of to determine if an individual experienced homelessness in the last year. And you can see from the data here, about 3% of the CHC group experienced homelessness in the last year, and that regardless of the group of the CHC self-identify race group is quite a bit higher than the non-CHC group. So only about 0.2% of the matched comparator population experienced homelessness in the last year. And then finally on this slide, using our ICES data holdings, OHIP, as well as CHC services data, we can ascertain and describe primary care utilization for these populations. And you can see that on average, the CHC group had roughly 3 visits to 3 primary care visits, I should say, to a physician that billed to OHIP in the 2 years prior to index. And they also had anywhere between 7 to 10 nurse practitioner or physician visits in the last 2 years at a CHC. Next slide, please. I talked a little bit earlier about our ICES derived cohorts, and we are describing here prevalence of select conditions from those data holdings. But one of the nice things we could do here again is that we can enhance those ICES derived cohorts using diagnoses found in the CHC data. And so that really gets us a more targeted prevalence estimate specific to the CHC study population. And I don't want to dive too much into individual prevalence estimates across the groups here, because up front, we've highlighted that there are socio-demographic and socioeconomic differences between these groups. So there's no standardization here, but just one of the observations that we can make here is that regardless of the race group in the CHC data, prevalence of rheumatoid arthritis, diabetes, hypertension, dementia, CHF, as well as mental health visits in the last 2 years it's higher in the CHC group than it is in the non-CHC, the matched population there. And I think that highlights the complexity of the CHC population. That's something that's well documented, but something that we were able to see here as well. So now we're going to move on to outcomes, starting with cancer screening measures. So the first slide here is colorectal screening, and the image that you're seeing is the proportion of screen eligible patients that are up to date with colorectal screening over time. Each line represents the self-identified race category. And you can see overall, there's a large drop around April 2020, which obviously aligns with the start of the COVID-19 pandemic. But looking at the individual categories of self-identified race, you can see that pre-pandemic, there are higher rates of screening for those that self-identified as Black, the blue line, and those that self-identified as white, the yellow line. But the largest decrease in screening rates relating to the pandemic was found in those that self-identified as Black, the blue line you can see. So there's the largest decrease related to the pandemic, and we don't really see that recovery in April 2022. Next slide, please. Moving on to breast cancer screening. Again, similar trends related to the pandemic here, where the overall proportion of individuals that were up to date with a mammogram over the study period, there's a large drop relating to the COVID-19 pandemic. But what we're seeing here is that there's consistently higher trends in breast cancer screening for the self-identified Black group compared to other groups. And that's consistent pre and post pandemic, or I should say the onset of the pandemic. And then last, wrapping up the cancer screening with cervical cancer screening. Again, there's the drop related to the pandemic, but I think the observation here is that CHC clients, regardless of the self-identified race category, had higher trends of cervical cancer screening compared to the matched CHC population. So that is a good news story for the CHC clients, CHC clinicians as well. Moving on to wait time outcomes, starting off with surgical volume. So for the wait time outcomes, we moved to annual estimates. We initially started off with 6-month estimates consistent with our other tables, but there was just a lot of noise in the data. So moving and aggregating to annual estimates allowed us to reduce some of the instability. And the reason we saw a lot of instability is that only about 4.5% of the study population had a surgical event within the index year. So this is really a subset of the total populations in our study population. And really surgical volume is a reflection of the differences in the population sizes. So we had about 171,000 CHC clients that were missing race data, and this group has the most number of surgical events, which I don't think is as much of a surprise there, just given that the total volume reflects the differences in the population size. But in terms of our wait time outcomes, if we move to the next slide, please. So if we look at the number of days from the first consult, so for when an individual was referred to when they first saw a clinician, Not a lot of huge differences, but marginally longer wait times for the CHC clients compared to the non-CHC comparator groups. On the absolute scale, those differences are fairly small, but you can see there are some gaps as well within the self-identified race groups. For example, the self-identify as Black population had shorter wait times than those that self-identified as white at the top, that yellow line at the top. And then our second wait time measure, if you go to the next slide, please. This is the number of days from when a decision to have a surgery was made to when that surgery actually took place. We can see there's a lot of noise in this plot and not a lot of clear trends that we can to make clear conclusions from. But important to note here that, you know, there's a number of different types of surgeries that take place here, and each individual as well has a priority level assigned to that surgery. The priority levels were fairly consistent with between groups, but another way we can look at this wait time measure is to look at whether surgery was completed within the target time frame, which is the next slide. And this really shows that, you know, with the onset of the pandemic, there were fewer surgeries overall that were completed within the target time frame, and again, marginally fewer surgeries were completed within the target time for the CHC group, regardless of the race category, compared to the matched general population, which is the orange line at the bottom of the plot there. So I'm just going to quickly wrap this up here with some strengths and limitations of our study. As with any ICES project, I think one of the strengths is the value in being able to link multiple data holdings and really to be able to describe the characteristics of the study population of interest. Using the CHC data in particular allowed us to ascertain self-identified race as well as other equity data, and that allowed us to really tailor the deliverable, the end product, to the knowledge user and the researchers to describe this population and primary care use in Ontario. Obviously, the big limitation of this work is the missingness of race data in the CHC data set. But despite this high missingness, we're really seeing this as a success. You know, despite the missingness, we saw some large gaps, some large differences in the profiles of the population. And so this data, this study is really an opportunity to promote and improve completeness of not only CHC equity data collection and use, but it's an opportunity for us all to do better, to encourage others to join in the improvements as well. So not just the CHC groups, but all to collect and use equity data across data holdings. This race information, self-identified race information, does not exist elsewhere at ICES, so it's really useful for us to have in-house, and you can see hopefully that is shown in this product here. So with that, I'm going to hand it back to Cynthia just to talk about implications and next steps of this project.
Thank you, Luke, for that presentation. In reflecting on the results that Luke has presented, we had a few points to suggest. Firstly, we believe the results of this project confirm that race-based data and equity data can help to identify inequities, provide direction for improvement of healthcare for racialized groups, and help to monitor progress in reducing health inequities. The goal is to improve healthcare access, experience, and outcomes of patients. The CHC equity data collection is a best practice, as you've heard Luke allude to, and it was able to identify gaps in care related to cancer screening and surgical wait lists. This can be used, the results can be used by CHCs for direct patient care and program planning, for health system planning, and also for health system planning to improve pathways to care, such as those in the Black Health Plan and provincial priorities, such as the Cancer Plan and high priority communities. CHC equity data indicates benefits of the CHC model of care as seen in the higher rates of breast cancer screening among Black population and overall high screening rates of CHC clients for cervical cancer. This could help inform where investments can be made for prevention services. However, we don't end here. The analysis doesn't end here because we know screening is just the start of improving outcomes. We need to look at the downstream effect and see how are the racialized groups actually performing in terms of actual outcomes from breast cancer, like death and morbidity, which we know is still high compared to other groups. Moving on, so it is important to expand equity data collection to other healthcare system areas to obtain a health system view. In addition, education, training, and resources should be put in place to support proper equity data collection and use. And proper engagement of the community in all aspects of the process is crucial, as well as public reporting of equity results for awareness and accountability. Lastly, this project can serve as a model for ICES's continued expansion of collaboration with community organizations on more ARC requests. We thank ICES greatly for their leadership in this area. Thank you. And with that, I hand that over back to Leslie.
Thank you, Cynthia, Luke, and Laura for that great presentation. Also, thank you. I know we have Shelley Ann Hall here, who was also involved in the project, as well as Jen Rayner and Angela Robertson, who couldn't be here today. I was also a member of this project team, and it's been a great learning experience for myself to go through this journey, excuse me, learning more about this project and how ICES can be a partner in this work. I now am going to open up the floor to questions. Just to remind everyone that you can post a question in the Q&A tab, which is next to the polling tab and the chat tab right in the middle. But to get us started, an earlier question that was submitted to us, and kind of it might go well based on how we saw the polling go, which was that about 50% of individuals are familiar with the ARC program, but it looks like the majority in today's presentation have not utilized the ARC program. So the question was, how do you start the process for requesting an ARC? And as we bring up maybe the panel just for questions, I'm happy to take this question. But the process is on our website at ices.on.ca. We have a tab for data services, and that includes an ARC request form. So typically we have someone fill out an ARC request form, and that gets submitted to our ARC team. The information will be on the sheet, and that information gets sent to us. There is an adjudication committee that looks at every ARC request that comes in. Typically, we like to have a consultation with a team prior to adjudication so we get an understanding of the project. And then that request, along with the information that we gathered in the initial consultation, is taken to the adjudication committee for approval. On the website, there's lots of information about eligibility requirements and what types of questions you might want to ask and what types of projects we offer. And I'm just going to give a little plug to a later session at the Research Forum. So at 11:30, there is another presentation by the Data and Analytics Services, or DAS team at ICES. The ARC program is under the DAS department. And their program presentation is called To REB or Not to REB? That is the question. So if you would like to learn more information about the ARC process, I would direct people to that session. And then one of another kind of follow-up comments that I wanted to make. Oh, and actually related to, I just got a question that said, do we need an REB approval to access the ARC? So actually, again, I think that later session would be a wonderful session to answer more detailed questions. But no, in general, we do not need an REB approval for an ARC project because it does fall within projects that are, the goal of an ARC project would be to evaluate a process that would help the broader healthcare system. So it's for the purposes of evaluation, planning, and monitoring. Next, we have another question. How did you identify matched non-CHC population and considering higher trends of breast cancer and cervical screening? Any further exploration on quality of care, health promotion activities offered at CHCs? So I'll open that one up to the panel.
Maybe I can take the first part of that in terms of identifying the matched non-CHC population. So with the repeated cross-sectional design, we were able to use the PC-POP data in-house. So PC-POP is a data set of everybody in Ontario that has a valid health card at a certain point in time. We were able to take PC-POP, remove those that were using CHC services, and that left us with a pool of individuals alive and in Ontario in the region. We could then refine that to those that were using primary care services, just like the CHC group. Obviously, this is limited to OHIP encounters. And from that, we can pull out individuals that had a similar profile in terms of age, sex, and geography.
Great.
I can take the second half around the quality of care for CHC for cancer screening. Unfortunately, our colleagues from the CHC and the Alliance, Angela and Jane Rayner, are not here. But one of the things we know is that CHCs have had a focus on breast cancer screening. That's one of their main indicators, performance indicators in the service accountability agreements. And there's been a lot of focus on cancer screening in the among the CHCs. They have also been using this equity data since 2024, the standardized equity data, to look at which groups among their populations are doing well in terms of screening and targeting them. So that may be one of the explanations around the good care. And then more recently, we saw some targeted screening initiatives, let's say for Black CHCs that are targeting Black populations that have really put a focus on increasing screening rates. But yeah, if there's someone from the CHCs in the audience, they could add to this.
Thanks, Cynthia. Thanks, Luke. So our next question is there an opportunity to work with the individual CHCs to improve the collection of race-related fields in those data? Another, I will just say, related question to this is what questions or methods were used by CHCs to collect the race-based data? I know Jen Rayner is one of the she would probably have some of the most detailed answers for this question, but I will speak to what I know is I did present to the Alliance for Healthier Communities a professional learning event back in January. And one of the focuses within that event was they actually had a quality improvement Olympics. So this really was focused on improving data collection and completeness. So I know there is a really strong focus on improving the quality of data collection. Now, you know, CHCs come from all different parts of Ontario with many different processes within an individual CHC. So I think it may come down to, each individual CHC maybe having different methods. But from what I know, there has been a major push to improve the completeness of data collection, not just for their own, knowledge of their client population, but also too for the downstream effects of being able to use information for art projects like the one we did this time around. Yeah,
I can also add to the piece around how the CHCs are collecting the equity data. We have there's been a push to collect standardized equity data, which started off with Toronto. Previously, all CHCs were collecting equity data, including the race-based data, and then it was standardized for the Toronto region, then Toronto Central Lane, to collect 8 standardized questions. These were actually then adopted by all the CHCs in the province. So they've been collecting this since 2015. And it's mainly, they collect this data, and we've been monitoring progress in the collection of this data. And one of the questions is around race. It was around race and ethnicity. So the information is collected for CHC clients, some mainly at their registration, but then information can be filled in by other providers as they see the patients for completeness purposes.
Great.
Thanks. Yeah.
So the next question is, how long does it take to get started on the research analytic work from the time of an ARC request comes in? I'm happy to take that one again, or Luke, I don't know if you wanted to add.
I can take that one, no problem there. Yeah, so once the form is submitted, we would typically meet with the knowledge user shortly thereafter, just to ensure feasibility. And after that meeting, the ARC team would have our adjudication meeting where we would discuss the project. And once it's accepted, it would be kicked off shortly thereafter. And there are some variables that that factor into the lengths. For example, if you're bringing in project-specific data, it's going to take a little longer. But typically, these can take anywhere from 2 months to 4 months from start to finish. Others are rapid response, and we aim to get those out within 5 business days. But those are a lot more refined.
Great. The final question in the chat is, apologies if I missed this at the beginning, but were Aboriginal health access centers included in the CHC group? If so, what measures were taken in terms of Indigenous data governance? So from, maybe I can speak first. From this perspective, no, they're not included in this study. So they were not factored in terms of having additional discussions with Indigenous partners. I don't know if anybody wanted to add to that. We have a few more questions coming in. Do you think population characteristics and prevalence of certain health conditions would have been higher for matched non-CHC group if undocumented folks were included, including those without OHIP, so OHIP eligibility or coverage, as I believe some CHCs may serve undocumented folks and are included in the CHC dataset?
Fair point, I think. Yeah, those without OHIP coverage would face different challenges typically. I'm not sure we would be able to pick them up in our data elsewhere, though. If they don't have an OHIP card, we wouldn't necessarily pick them up in OHIP billings, for example. But point taken that yeah, there are people in the matched group that are or there are people missing from the matched group that maybe could have been included. That would have been maybe a closer comparator. We matched on age, sex, and geography, which is, just trying to get a similar profile of people in terms of socio-demographics. There could have been differences as well if we matched on other characteristics, other clinical variables that we could have maybe pulled. But there's a bit of a trade-off when we do this in terms of our overall match rate, because it gets more and more difficult to match when you start adding in more characteristics. So matching on just age, sex, and geography kind of got this generalizable population, and still allowed us to retain the comparator group in full.
Great. And our next question, what are some of the opportunities and challenges with using this data to inform practice and interventions to support high-risk communities? Go ahead, Cynthia.
Yeah, so some of the opportunities for using the data is that it helps to inform what are the issues for some of the priority populations. For example, the Black population, you would see where they may need support, or the other non-racialized populations. So this can be factored in along with looking at other information to obtain a better picture, to look at targeted things like targeted funding or targeted strategies to help with that. So for example, we have the high priority communities strategy that started during the pandemic, which focused on supporting marginalized groups, people living in areas with high proportion of marginalized groups, and enhancing COVID supports, and now more so preventive care for them. But this type of data, showing the disparities and inequities in health access and outcomes, has been beneficial in terms of helping to target the areas of need.
Great. Maybe I'll just add too that, one of the main messages that we got when we shared this work with the Black Health Equity Working Group was, despite the limitations, knowing that, I think what we saw in the presentation is that there is a high level of missingness, that we don't want to just throw it all out. And really the use of this data is driving then the better collection of data. So it's a very iterative process, knowing that, this information, despite its limitations, we want to be able to use it and find those signals to then start going into the next process of better collection and then more use more broadly. So I just wanted to add that I think, even though there are challenges, I think we are making progress, knowing that there is, this data available, at least for some populations, in some of the data sets that we have at ICES. So that concludes the questions that we have available in the Q&A tab. I know we're actually just a few minutes short, but I'm happy to give everyone 4 extra minutes of a break. I want to thank everyone again for attending this session. We really appreciate your attention and the fact that we get to share this work again with a broader audience. I want to let everyone know that next step is a 15-minute break, and then at 11:30 will be the next sessions. And just like I mentioned earlier, if you want to learn more about the ARC program and our data and analytics services branch in general, you can attend the to REB or not REB. That is the question session coming up at 11:30. So thank you again to everyone, and I hope you enjoy the rest of the forum.